Hello, my name is Gary Himes, and this is my final project for ATRN 8110 Comparative Effectiveness in Athletic Training. The topic of my research was my elbow hurts, but I don't want surgery. Rehab versus surgery in the overhead throwing athlete. My clinical question is in overhead throwing athletes that sustain an ulnar collateral ligament sprain of the elbow, is the length of time to return to play shorter if the athlete does a rehabilitation program only, or if the individual has surgery to repair the UCL or ulnar collateral ligament of the elbow? The two types of interventions that I chose to do for this specific project were surgery and rehab. Surgery of the ulnar collateral ligament is considered the gold standard, which requires a 12 plus month rehab as well as throwing program to return to play on average. Again, that can be modified based on the person's position that they play, the sport they play, their healing rates, and things like that, which we've discussed previously. The other option is the rehab intervention, which I chose to focus on for this specific topic. It's a 6 to 8 week program focusing mostly on grade 1 and 2 types of injuries, to include a throwing program. Again, the throwing program is based on age, competitive level, position that the person plays, etc. The rehab that we're dealing with is something that is very new. The first documented rehab only criteria that was used to return a throwing athlete to sports was in 2006, and we've learned through this class that interventions can take up to 17 or more years to be integrated into someone's clinical practice. So obviously we have some time left with this rehab intervention to be able to be used on a regular basis in the rehab setting. So that's one thing that I wanted to focus on with this is rehab and trying to explain a little bit about the rehab part of this intervention. You also notice on the bottom right hand corner there's a just a quick anatomy review of the parts of the elbow to include where the ulnar collateral is. There's also a link to this that was the picture is actually an interactive picture which if you use the link you can look at the picture in that type of manner. My patient population will consist of male or female overhead throwing athletes ages 18 to 24 that see the local physicians for medial elbow pain. The diagnosis of a ulnar collateral sprain will be used via an MRI. The physician will then determine what group the patient will go into based solely on the results of the MRI. Some of the inclusion criteria that we will include, obviously, an overhead throwing athlete, male or female, ages 18 to 24. The injury must be in their dominant arm, the one that they would normally throw with or use to throw. They must not have any type of ulnar collateral issues in the past or no type of injury previously to the elbow. Exclusion criteria, any previous ulnar collateral ligament injuries, any previous surgeries or issues with the elbow, injury to the non-dominant arm, and any type of a complete rupture of the ulnar collateral ligament will automatically disqualify them from the rehab plan. Our outcome variables and procedures, we're going to be using the local athletic trainers. The physician as well as the researcher will design the rehab protocol that they would like to use. Again, based on the results of the MRI, if the physician feels that there is a grade 1 or grade 2 injury with the UCL, the physician will put that person into the protocol for rehabilitation if it's approved by the patient and the patient's family, if that is part of the decision-making process. The research design is a clinical trial. This is the best option. The researchers will be deciding who is placed in what category, so there's no way we can do any type of random control trial. So we will be using, we could use an observational type of research, but at that point the researcher and the physician will not be able to dictate what the rehab protocol is. So we would have to use whatever the athletic trainer is using at the time. The stakeholders, obviously, the most important one would be the patient's family. The physician is obviously a stakeholder, the athletic trainer. Some secondary stakeholders would be the insurance company, the coaches, the school, and potentially the team and stuff like that. So that's who we're looking at as far as stakeholders go. The significance of this study is very good, actually, because there's very little actually on the rehab aspect of ulnar collateral ligament sprains. The earliest article that I could find that dealt specifically with the rehab with no surgical option was 2006. And we learned previously in this class that interventions take up to 17 years to be integrated fully into the clinical aspect of an individual. So obviously we're only 10 years in at this point right now. We're still looking at another potentially 7 to 10 years until this is actually fully integrated into individuals' clinical aspects. There is a success with rehab. The rehab has been shown in 85% of individuals with grade 1 or 2 to be success. Because of the lack of rehab, there is no research currently as to if those individuals have any issues later down the road. Maybe a year or 2 or 3 after their rehab session, even if they are able to return to play, what has happened to them then. And it's much less invasive. You can see the picture in the lower right-hand corner. This is just a general picture of what a surgical scar would look like for someone who has had an ulnar collateral ligament repair and or an ulnar nerve transposition. And just the invasiveness of the surgery in general, the moving of the nerve, the drilling in the bone, the recreation of the ligament, it's all very invasive. So the significance of this in athletic training, though, is there is an option prior to surgery, and I think as athletic trainers we have that responsibility to our athletes if we feel it is in their best interest. And this is where the researcher would have to have a very, very good relationship with the physician to be able to determine which athletes would be able to go into which group, especially which athletes would be very suitable for the rehab group. The feasibility of this study is probably the thing that I feel is the most difficult thing to do for this study, particularly someone like myself living in Pennsylvania or someone just living in a cooler climate to begin with. For instance, if we would focus mostly on baseball players, since mostly baseball players are the ones who receive this injury. Baseball in Pennsylvania can only be played maybe 5, maybe 6 months out of the year, depending on the weather. Someone who's down in a warmer climate would be, and where baseball and softball and those types of activities can be played more on a year-round basis, I feel would have a greater chance of conducting this research in a timely manner, which is obviously something that's feasible to do for them. Someone in Pennsylvania or in a cooler climate could use the NATA website and go through and find athletic trainers and have them, send them all the information on their UCL sprains and stuff like that. But I feel one of the other issues that I would want to use with this is, in conjunction with a physician and some other athletic trainers, is develop a protocol or a specific outline of exercises that could be done specifically for the rehabilitative individuals, so that everything's kind of consistent. We know what to expect, we know how to expect it, and things like that as we move through the rehabilitation stage of this intervention. In conclusion, I think that the rehab option that is being presented is a viable option for a grade 1 and or grade 2 ulnar collateral ligament sprain. However, there is just not enough research out there yet for it to be fully integrated into a clinical setting that would allow an athletic trainer to feel confident in the ability of the rehab to be able to, suggest it. Hopefully within the next couple years, we're going to rely a lot on the expertise of individuals in professional throwing sports to give us the data that we need to be able to integrate this more into a collegiate and or high school setting so that we can better serve our athletes. I look forward to hearing the feedback from all of you this week, and I appreciate you listening to my presentation. Thank you.